Hello and welcome to our new topic. Have you ever wondered how our food grows mold on if left alone in open? What if the mold and similar things would rather choose us as their next destination? We live in an environment where we constantly face a variety of pathogenic fungi. Most of the times we successfully thwart the danger away, but sometimes they overwhelm us and produce a variety of fungal infections adversely affecting our health, and hence we use various drugs to get rid of them. Those drugs are antifungal drugs, also called antimycotics, and we will learn about them in this series of lectures. So we will try to make it a bit more comprehensible, simpler and straightforward. And let us hope that by the end of this lecture you are able to grasp all these learning objectives which are shown here. Pathogenic fungi are divided mainly in two groups: those which cause superficial infections, that is, skin and appendages, and those which cause deep tissue infections. Most common infections belong to superficial group. When we say appendages, that means the hair and nails on skin. Some of these are imperfect fungi because they lack some of the typical characteristics of fungal organisms. And these include epidermophyton, microsporium and trichophyton. The other important group of fungal pathogens are called tinea or ringworms, which form a ring-shaped lesion on skin showing a reddish-pinkish hue at the periphery. It affects different parts of the body. If it is head, we call them tinea capitis; if it is nails, tinea unguium. Then if it is body, tinea corporis. If it is feet, tinea pedis, and so on. So the third one is candidiasis, which is a type of yeast. And candidiasis, mainly the Candida albicans, is part of the normal flora in certain parts of human body. For example, oral cavity and vagina. And under certain situations, these overgrow and form a curd-like whitish patchy layer over the mucous membrane that is called thrush. Candidiasis could be superficial or deep. You can see that deep fungal pathogens are many. Some are dimorphic, which means that due to difference in atmospheric conditions, they may exist in two forms. Further detail about them is out of our scope, as the topic is mainly about drugs against fungi. For therapeutic purpose, we exploit the characteristics of fungal cells which are different from the host, in this case human beings. Important antimycotic targets are shown, and as one can see, it includes differences in cell boundary, metabolism and genetics which serve as plausible therapeutic targets. For example, fungal cell membrane has ergosterol as a constituent instead of cholesterol and thus serves as a drug target, as explained in next slides. Here you see the antimycotics being classified according to molecular nature. There are four major groups with multiple subgroups as shown: the antifungal antibiotics, allylamines, azoles and antimetabolites. Interestingly, all begin with letter A. The azoles are the most commonly used antimycotic drug group, followed by allylamines. The drugs shown in red color font are most important ones. The third group is azoles, which is the largest group. The fourth is an antimetabolite. Alternatively, the drugs can be classified in four groups according to antimycotic targets or mechanism of action, as shown in this diagram, namely, cell wall synthesis inhibitors, drugs with action on cell membrane, drugs causing microtubule function disruption, and nucleic acid synthesis inhibitors. Echinocandins are the newest class of antifungal agents to be developed. They are large cyclic peptides linked to a long-chain fatty acid. Caspofungin, micafungin, and anagulafungin are the only licensed agents in this category of antifungals, although other drugs are under active investigation. These agents are active against Candida and Aspergillus, but not C. neoformans or the agents of zygomycosis and mucormycosis. Echinocandins are available only in intravenous formulations. So these antimycotic cell wall inhibitors will inhibit the beta-glucan synthesis in the cell wall, which is an important constituent of the fungal cell wall. Adverse effects are not very common, but it tends to induce hepatotoxicity, which gets worsened or multiplied if you couple this with another hepatotoxic or potentially hepatotoxic drug like cyclosporin. It is effective against candida infections as well as aspergillus, which is the strength. We don't have many drugs against aspergillus. Amphotericin B remains the antifungal agent with the broadest spectrum of action. It has activity against the clinically significant yeasts, including Candida albicans and Cryptococcus neoformans, the organisms causing endemic mycoses, including Histoplasma capsulatum, Blastomyces dermatitidis, and Coccidioides immitis, and the pathogenic molds, such as Aspergillus fumigatus and the agents of mucormycosis. Some fungal organisms such as Candida lusitanii and Pseudoescherichia boydii display intrinsic amphotericin B resistance. This antifungal antibiotic source is Streptococcus nodosus, and it's poorly water-soluble. It binds ergosterol in mycotic cell membrane to form membrane pores, and the pores would lead to loss of the intracellular nutrients and water and the minerals, and of course the cell would dehydrate and die. Therapy with amphotericin B is often limited by toxicity, especially drug-induced renal impairment. This has led to the development of lipid drug formulations on the assumption that lipid-packaged drug binds to the mammalian membrane less readily, permitting the use of effective doses of the drug with lower toxicity. Liposomal amphotericin preparations package the active drug in lipid delivery vehicles, in contrast to the colloidal suspensions, which were previously the only available forms. The toxicity of amphotericin B can be divided into two broad categories: immediate reactions, related to the infusion of the drug, and those occurring more slowly. Infusion-related reactions are nearly universal and consist of fever, chills, muscle spasms, vomiting, headache, and hypotension. They can be ameliorated by slowing the infusion rate or decreasing the daily dose. Premedication with antipyretics, antihistamines, meperidine, or corticosteroids can be helpful. Nystatin is also a poly-NA macrolide. Much like amphotericin B, it is too toxic for parenteral administration and is only used topically. Nystatin is currently available in creams, ointments, suppositories, and other forms for application to skin and mucous membranes. It is not absorbed to a significant degree from skin, mucous membranes, or the gastrointestinal tract. As a result, nystatin has little toxicity, although oral use is often limited by the unpleasant taste. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!